Good afternoon and welcome everybody. I'd like to ask one of our guests today, Barbara O'Neill, to do the acknowledgement to country.
I'd like to acknowledge the Gadigal people of the Eora Nation on whose land this webinar is being held today. I'd also like to acknowledge elders, past, present and emerging. Thank you.
Thank you, Barbara. So today we're having a conversation with three people representing older people from three diverse communities that haven't had much attention during the COVID-19 crisis. We'd like to unpick some of the effects of COVID on these communities to create a better understanding. We want to know what the issues are, and at the end of the discussion, we're happy to take questions from the audience, which you can send in via the comments section. Ask questions in the comments section in the login that you've already logged into today. Whilst we refer to the three different communities as called Culturally and Linguistically Diverse, Aboriginal and Torres Strait Islander people, or Lesbian, Gay, Bisexual, Transgender and Intersex people, older people, it's important to point out that these communities are not homogenous, and people within a similar group are not all the same. Everyone will have a different way of describing themselves. So now to our remote speakers, a big welcome. Firstly to Sam Edmonds. Sam is Hi Sam. Sam's the Managing Director of Ageing with Pride, her own consultancy that specialises in developing, delivering and evaluating projects, programs and services that are respectful, person-centred, culturally safe and inclusive of LGBTI elders and older people. Barbara O'Neill is an Indigenous trauma and recovery practitioner specialising in the support of care leavers of institutions and from the stolen generations. Welcome, Barbara. And now to Cecilia. Cecilia Milani is the Manager of Partners in Culturally Appropriate Care, also known as PCAC, New South Wales and ACT, with the Multicultural Communities Council of Illawarra, also referred to as MCCI. It's a multidisciplinary service that has been supporting multicultural communities for over 45 years. So moving on, I'd like to ask you all a little bit about the health disparities of older people in your communities. Has COVID put your communities at greater risk of severe consequences from COVID? And I believe this might be particularly relevant for Sam and Barbara. Could you each give a brief overview? We'll start with Sam, please.
Thanks, Diana. I'd just like to start by acknowledging that I will be using the acronym LGBTI, but recognising that there are traditional languages and identities beyond those letters, and just to acknowledge people of diverse sexualities, relationships, genders and bodies. So LGBTI people experience greater rates of chronic health conditions, obviously the rates of HIV, and therefore may have compromised immune systems. We also know that LGBT people use tobacco or smoke at substantially higher rates than the general population. And with COVID-19 being predominantly a respiratory illness, that can be obviously especially harmful to smokers. We also know that LGBTI people have greater mental health disparities, particularly in relation to higher rates of depression and suicide. And this can place LGBTI people at greater risk when faced with physical distancing measures and greater isolation, as was required during the sort of main parts of COVID and still continuing now. So this means there's the sudden loss of community support and those cultural spaces that are so important. It creates barriers to maintaining connection with families of choice and community, and it can potentially put LGBTI people in unsafe or unsupportive environments.
Thanks, Sam, for that comprehensive assessment. Barbara, can we go to you next? How has COVID-19 affected your community and what are some of the health issues?
We really don't have data out of our communities at the moment. It's just mainly what we're hearing is on the ground information. One of the major things that happened for us was that our ACHOs, otherwise known as Aboriginal Community Controlled Health Organisations, got a very rare opportunity to run with this project as a whole of Aboriginal concept. And it was very successful. They are trusted. They are in the community. They're always on the ground. And we value our elders and our older people very much. So the younger people in the community took it on as their responsibility to keep the older and elder people safe. Aboriginal people, because we have a lower mortality rate and we have quite a few chronic illnesses, we're aware that this could have been devastating and catastrophic because we're only 2.5 of the population. So, and there was also, it was really good that our Aboriginal controlled health workers were able to run with this, because there is a historical context of fear of hospitals and a lot of medical people because of, as I said, historical context. So to get Aboriginal people to go to a mainstream health organisation or hospital would have probably been quite difficult. So because the ACHOs were able to go in on the ground and run with it and stay with it, their communication was amazing. And we put that down to NUTCHO as well, which is the national organisation. Some of the posters coming out were groundbreaking. They were really excellent. And there was the testing was available for people so that it was local, and the testing was in their own community. So that also helped a lot as well. We did notice a lot of food insecurity. That's coming from the Junction Neighbourhood Centre. We noticed insecurity, but not necessarily in the places where a land council is present, or the land councils did a lot towards that. But we found a lot of people living outside of the Aboriginal community who are Aboriginal were really dealing with serious food insecurity, which we supported them with.
Thanks very much, Barbara. And I believe you also had a lot of success with you. It's known that there are higher rates of incarceration of Aboriginal people, but you were able to keep the people safe to date, which is a success, isn't it?
Yeah, Justice Health did a fabulous job there.
Yeah, thank you. Cecilia, would you like to add the multicultural perspective, please?
Yeah, sure. Similarly, people from culturally and linguistically diverse backgrounds are less likely to access services, generally, including health. So you can imagine what it's like in a situation like COVID. Just to give an example, there was 17,000 COVID testing or tests undertaken in the Illawarra, and from the statistics, there was only 5 that required interpreting, which indicates again the lesser uptake of people from multicultural communities. There are higher levels of isolation for people from multicultural communities. There's burnout of older carers. And broadly, there's a lack of understanding of the situation. By the time the information came out about COVID, and there were so many other misconceptions in the community. I mean, for example, even when I asked my mum what she thought and I told her about, the whole thing about what's happening with COVID, how she shouldn't be going out or visiting friends, her response was, oh, that's interesting. She said, I thought we just had to stay away from the Chinese. So these were just some of the misconceptions that were going on about the whole COVID situation and what that meant. This leads to a lot of frustration and anxiety. I mean, for example, even older people that have their older children come and visit, if they are not engaging in proper process of washing their hands and the isolation, that contributes to their anxiety as well. So it's a really collective, I guess, of just not knowing what's going on and just getting bits and pieces that leads to a lot of confusion and certainly a lot of anxiety amongst the CALD communities.
And did you get any feedback about, I know SBS was promoting their ads about COVID in all languages. Was there any feedback to your groups about whether that was effective, whether they'd heard any of those ads?
Yes, it was. That was quite good. Again, it came out a little bit later. It wasn't out straight away like the general information, but some of the feedback and some of the research that was undertaken by SBS, there are some communities that actually came across some material in infographics. So even though it was in English, but there was enough information in the infographic for them to be able to get an idea or a sense of what's going on, even though they might not have been able to read the language. So again, it's about, appropriate communication methods to engage with those communities and getting the messaging across. But yes, definitely SBS certainly contributed to, some great messaging there.
Great. That's really good to know. Another issue with some of the communities are historical factors and ongoing discrimination that's been experienced in the past and is still being experienced, as our recent demonstrations have shown. This would make accessing support services, one of you alluded to earlier, much more difficult. They'd be less likely to come. Can I get you to comment individually? We've got a chart up about some of your comments that you're going to make, but can I go to you first, Sam? In fact, I was stunned at the first comment. That was something I didn't know about.
No, it's not common knowledge. So during the World War, the Nazi concentration camp badge, so various different groups were given different badges to identify them, and those who were homosexual were given a pink badge to identify them as homosexual. Around 65% of gay men in the concentration camps died between 1933 and 1945, and we also know that many of the gay men who were released from the concentration camps were then put back into prison because homosexuality was still illegal. So they didn't even have any relief as the rest of the prisoners. The 1950s and between the 1950s to the 1980s, people could be sent to be cured of your homosexuality, so electric shock therapy. Then from sort of 1968 through to 2013, the Diagnostic and Statistical Manual of Mental Disorders had various classifications of trans and gender diverse people, including classifying them as having a sexual deviation or psychosexual disorders. And this has changed to gender dysphoria now since 2013. In 1973, we know homosexuality was actually finally removed as a mental disorder from the DSM. And a lot of the changes are very, very recent history. So 1997, Tasmania was the last state to decriminalise homosexuality. So that was, 23 years ago that finally across Australia you weren't, your rights were recognised in that sense. But it wasn't until 2009 and the same entitlements inquiry that we actually started to see family relationships recognised for LGBT people. In 2012, we had the National LGBTI Ageing and Aged Care Strategy, so the first time that we actually started focusing on the needs and issues of older LGBTI people. And that actually ended in 2017 when we brought in the Diversity Framework and the LGBTI Action Plan. During that time, we also had in 2013, the Sex Discrimination Act was finally amended to prevent discrimination against people because of their sexual orientation, gender identity or intersex status. So really only, in reality, 7 years that we've seen discrimination against LGBTI people actually made illegal. And in 2017, we had the marriage equality. Yeah. And then in more recently, in 2019, finally, the World Health Organization removed gender identity disorder from its manual of mental diagnoses. I guess the main one we do need to comment on, though, is that intersex people are still fighting today to stop unnecessary surgeries being performed on their bodies when they're younger. And we know that very many intersex people suffer lifelong physical and emotional effects from such interventions.
Thanks, Sam, for that very broad description of all the issues and barriers that LGBTI older people would face. Barbara, can you comment on the Aboriginal perspective, please, historically and discrimination-wise?
If you look, say, born in 1952, by the time they were 15 years old, they were only just then being told that they were going to be accepted as a human being, which was when the vote came in for Aboriginal people to be able to vote, the referendum. So can you imagine for the first 15 years of your life being told that you're not really, you're flora and fauna, you're not really a human being. So imagine how you were treated when you went to a hospital or a doctor. Now, there is evidence that there was serious racism within the hospital and medical system. That has been evidenced. Since then, there's been apologies from various health organisations. But imagine now that you're 15 years old in 1967. You've been identified as someone that's not worth helping or saving. You're now in your late 60s and you have got a pandemic coming down around you. You are not going to, historically, from a historical context, you're not going to want to go into a hospital, because Aboriginal people believe that when you go into hospital, you either don't come back out, or while you're in there, your children will be taken. They still believe that, and it still happens. So the thing is, it was really good that we had our own Aboriginal community-controlled health organisations, because you can imagine, after what I've just told you, the trust that has been engendered when we see our younger people growing up and becoming nurses and doctors and health workers. I don't know if it would have worked in any other case if Aboriginal people had to go to mainstream health. Now, mainstream health is bending over backwards to fix up the problems from the historical context. But the thing is, if you're in your late 60s and you grew up through that era, you are not going to want to go to a hospital. You are not going to want to get tested. So it was really important that the Aboriginal community-controlled health organisations were given this to run with. And there's generations, that has put a terrible scar into the community. And children are still being taken today. And so there's no reassurance that hospitals are safe, or that the medical community is safe for Aboriginal people. I'm not saying everyone, but definitely quite a few people.
And do you want to comment on the fact that the deaths in custody, Travis, can you just put that slide back up? The deaths in custody report in 1991, there have been 434, I believe, deaths since then. So we're still fighting on that front as well.
When you look at the deaths in custody, many of them are stemmed from existing medical conditions that were not tended to. So there's that terrible stress on Aboriginal families when their people go into jail and have an illness that they will not come back out. They are just not listened to. And David Dungay, he was one of the people who died in custody, and like George Floyd, his last words were, "I can't breathe, I can't breathe, I can't breathe." And so this is still happening today. So we have our communities trying to deal with the issues of deaths in custody, and women, mothers who are pulled up because they're either seemingly drunk or the police don't like the way they're walking or the way they're behaving or talking. So so whole families are losing their mothers. They don't have a matriarch to move on with going forward. They don't have someone who's going to reach this age where we're talking about older people. That won't even be a conversation for some of those families about older people.
All right, thank you. Cecilia, As Sam said earlier, it was a fairly racist society in the early century. I wonder if you'd like to comment on the multicultural perspective as well, please.
Sure. There are obviously similar things that have occurred with multicultural communities as well. I mean, some of the systemic racism is being driven by policy frameworks. Some are intentional and some are unintentional consequences. But if we just, take a look at the impact of the White Australia policy, so that didn't only affect the migrants that were necessarily coming in, but even the attitudes of the people that were living at that time. And those people that now develop dementia and revert back to that timeline, they, become racist and significant all over again. I mean, we've got instances or examples of where someone that fought in a war against a particular group is having a significant impact on them. So when someone comes in that, might be a different skin colour, approaches the person, he'd go into a fit of rage. And to the point where even some furniture had to be removed from the residential care facility. So these are just some examples of, the circumstances that can be long-term, not just for the individual themselves, but also other people that have had nothing to do with what was happening at that point in time. So those sort of policies and behaviours become entrenched. And they are a lot more difficult to change. And even if we think about 1975, when the Racial Discrimination Act was brought in, that was 45 years ago, and yet we're still talking about racism. So again, it is something that is not something that can be easily changed simply by bringing in new legislation. It is a societal entrenchment that needs ongoing work and ongoing conversation. I think 3/4 of the issues can be solved if we're actually prepared to talk about it. But nobody seems to want to talk about racism. And unless you talk about it, you won't be able to solve any of the issues and actually deal and understand how do we move forward from here.
Exactly. I'd like you to move on now to talk a little bit about the effects of COVID directly on your communities. We might go to Sam.
Okay, thank you. Look, I wanted to pick up a little bit on what some of the others were saying as well. I mean, we know that those historical and continuing experiences of discrimination make accessing services, particularly health services, much more difficult for LGBTI people. And we also know this is exacerbated by structural and systemic barriers. And we know that trans people in particular report high levels of discrimination and stigma when they're trying to access health services. So obviously this all leads to greater disparity in access to the services LGBTI people need. So that puts them at much higher risk during COVID-19, just simply because they will be discriminated against, or they feel they will be discriminated against because that's what the life experiences have been to date. We also need to think around access to medications has been an issue during COVID-19. Now, while medications were available for those with HIV and those who are taking gender-affirming hormones, any kind of planning to try and get more than 1 month's supply could be quite difficult in some areas because a lot of chemists and were saying basically, you can only have 1 month. But that could be really problematic. If you're living by yourself, you don't have family or you don't have friends that could go and pick up your medications for you and you're isolating, then how do you get access to those very important and necessary medications that you need? I know chemists were also doing delivery, but then you're trusting someone that you might not know to deliver medications to you, and are they a safe person? And is there potential for discrimination to happen, and you don't know if that's going to happen? I do know, I heard through that there was a doctor predominantly working with people living with HIV, and he's had a 45% drop in patients. So does that mean that people are skipping medications because they're afraid of what might happen through COVID-19 and exposure to the virus? The other sort of area, in terms of gender-affirming surgery as well, which was cancelled, and that can be quite distressing, particularly for those where gender-affirming surgery is actually fundamental to their health and well-being. And, this sort of uncertainty of when that will become available again can obviously cause further distress. And layered on top of all that is just the other experiences of just everyone in the general population around the impact of COVID-19, the uncertainty of what it might mean, the uncertainty of what's going to roll out, how things are going to happen, the impact on you and your family around you. So there's so many things sort of putting pressure and pressurising LGBTI people around COVID-19 and how to cope with that and make it through and get the supports they need without actually necessarily being able to get out there and engage with their communities and their people.
Thank you, Sam. We will be talking about some of the supports and some of the solutions in a minute. But Barbara, can I just get you to quickly talk about some of the other effects? You were talking to me a lot about lockdown being a trigger for older Aboriginal people. Do you want to have a word on that, please?
Okay, I can't speak universally for older Aboriginal people, but I have spoken to some people that are outside of a community that live in the mainstream community, and a lot of them remember being in homes, on missions or in homes, girls' homes, and just any sort of governmental decree that they must stay in the one place, they must get permission to move. This has triggered memories, especially about the homes. It really has. They're finding that I've had some clients that are single women, but they are grandmothers, and COVID-19 has had a huge effect on them finding housing. They are homeless. And they are also grieving that they don't have the space to see their grandchildren. Even though visiting's limited, they still feel that they're a terrible example to their grandchildren because they don't have a permanent home. This is caused by poverty and also a lack of wanting to access services due to the historical context of either being part of the stolen generation and colonisation. We don't know yet. We don't have any figures out, but I'm only just telling you about my experience as a community worker. I'm really worried about a lot of the single older women, not single because they're not with a partner, but they do have families. They're not accessing the doctor. They're not accessing anything because they think that they're being told to lockdown, and lockdown means lockdown. And you can't make a decision in that environment.
No, thank you, Barbara. So some similarities as well with LGBTI older people. Cecilia, you dropped out earlier.
Sorry about that. I don't know technology.
That's all right.
I love it.
Do you want to talk about your communities are very engaged with families. So how have the COVID situation affected them in particular?
Well, going back to what everyone else was saying as well, keeping in mind that a lot of multicultural communities, their journey to Australia is quite unique. Some of them experienced war. Then we've got also a lot of refugees that are, in Australia at the moment, and some of these sort of lockdowns certainly brings back memories for them. So there are things that affect people in that respect as well. But the engagement with family has been quite tragic, I suppose, because there's a lack of understanding by many of them, particularly the ones that are receiving services, about, well, how come this worker can come into my home but my daughter or my son or my family can't? So again, this is just about not quite understanding, how it all means. And community engagement is very important for the culturally and linguistically diverse communities. So it is something that they normally do together. They socially. So this has really proved a challenge. Even from my own personal family, if I think of my mother-in-law, who's relatively engaged with technology, even at 83. So, we will FaceTime and do those sort of things. But even for her, she said, I just need to actually talk to a real person in real, not someone on a screen. And she started to get, into a depression as well. And so this is something that, again, it's fantastic technology. Temporarily, that can, help people and support people. But those ones that, lack the human actual interaction and talking, which is most of the people, is quite challenging. I could only imagine for the groups that we've been working with that have no technology at all except for a telephone. So they've been relying on that phone call to stay in touch and actually talk to someone. So it's been a real challenge.
Thanks, Cecilia. I'm going to move on now to solutions because our time is slowly running out. And Cecilia, I know you talked to me about teaching people how to use Zoom, etc. Do you want to talk about some of the solutions in your communities that you've been trying, that your organisation's been trying?
Sure. That's been a lot of fun. I have to say that is the fun part of it, was just working with the seniors and getting them engaged with Zoom. So we've been doing things like music and exercise, organising in-language radio programs, sharing stories on closed Facebook pages, but a lot of them has also been the welfare checks, making regular phone calls to just to have a conversation. We also implemented collaboration, you could say, with the local, some of the local restaurants to organise culturally appropriate hot meals delivery, so that people could actually get a hot meal and connect to somebody at least once a week. The other interesting thing is that our organisation also runs the Meals on Wheels service, which are frozen meals. And we've had instances in one particular gentleman who, instead of ordering, because with frozen meals you can order a whole week supply, he was actually ordering on a day-to-day basis because he just looked forward to someone visiting and delivering it. So this is how much of an impact that can have on the people who are quite isolated.
Yes.
But that part of it has been quite amazing, the response from people. And we've sort of come to a situation where there is nothing that is, or the attitude that this is not part of my job description. We pretty well do everything that the individual might need to be able to connect. Even the example of where we assist a lady to get her camera to work on her computer so she could connect to family locally as well as overseas. And the smile on her face was worth $1 million, just for her, when she could see that she could see the face and talk to someone that is in the family in the country. So that was amazing.
So some very creative solutions there. Can we move on to you, Barbara? Any solutions in the Aboriginal community?
In the community that I work in, with the people that are living away from the major Aboriginal community, we have daily phone calls, and we have also, I have an organisation behind me, thank heavens. So if anyone needs to face some tension, I just get in touch with my organisation and a worker will be there. We've been organising food parcels, fruit and veggie boxes, which have been really good because they're showing the person that they're not disconnected. Also, I think that Zoom has been great because I've had some friends who really cannot have that interpersonal conversation that they're ongoing without a face to look at. And we also had the situation where my organisation will, on an emergency, let someone come into the office and set up a Zoom call for them. And we're looking at making that something that's regular once community centres open up again. But we found that what people mainly want is to know someone's out there, be able to talk about their problem, us come back with a solution to the problem, and then they know that they're also their solution solved. Their problem solved.
One before, sorry. Thank you very much. And Sam, to you for your community's solutions.
Very similar things to the other two communities. We do have the LGBTI community visitor schemes, and they've been doing some great work in connecting with older people in residential care and obviously still at home. The National LGBTI Health Alliance is doing some great work around intergenerational connection, so connecting older LGBTI people and younger LGBTI people and encouraging this to happen, which is a really important part of reconnecting community. We have Life, which is an anonymous and free LGBTI peer support and referral phone line that people can access. And look, so many LGBTI organisations and organisations like Intersex Human Rights Australia and Trans-Pacific organisations and HIV organisations have some really resources and some really practical and useful tips on their websites, and have been doing some really great supportive work out there in the.
Thank you very much. And there's a slide on the resources on the screen. We might move on to take some questions from the audience. I've got a few on my sheet here. Jane, have you got one to add? Okay. So for Barbara, how have Aboriginal communities dealt so effectively with safety in communities with so few positive COVID cases? Was there better coordination, collaboration? How did they do that? Barbara, are you muting again?
I can't speak for, as I said, I can't speak for culturally. I can't speak for every Aboriginal community. But what I know historically is that Aboriginal people are very well aware of the power of a pandemic and an illness that goes through the community. So I believe that was a huge factor in safety, because historically we've had a lot of that. Some of it was deliberately placed, others was because we didn't have the antibodies or the resistance to a lot of other diseases. So because of Aboriginal controlled health networks, they just stepped straight in, and the communication was fantastic. As I said, the posters were really, really good, and people just realised we're all in this together. And also, it's our great love for our elders and our older people that community together to protect them specifically.
Thanks, Barbara. Cecilia, a question for you. What examples have you encountered where cultural practices have had to be abandoned due to lockdown?
Not so much abandoned, but certainly changed. If we about Ramadan, that was happened between April and May, the Jewish Passover, April, certainly changed things. I mean, even if you think about, for the Christian religions that celebrate Christmas, can you imagine celebrating Christmas under complete lockdown? It's just not the same. So you do what you can for those ones that were able to engage with technology, that helped. But for the most part, it was quite challenging for many of the communities to have such a major celebration during this period. So again, it's not something that's abandoned, but even things like daily or weekly religious practices for those, that to go to the mosque or to go to church, or all of that has had a big impact through COVID. So there's been a lot of impact on called communities or culturally linguistically diverse communities in many aspects of their life. It's not just a matter of not being able to go, pick up your own groceries or anything like that. So it's very much every other part of their life as well.
Thanks, Cecilia. And Sam, a question for you. What challenges do LGBTI face in the new normal post-lockdown and self-isolation?
Look, I think absolutely the same challenges as before we went into isolation. We still know that the religious discrimination bill is sitting there, even though it's not been moved on during the time of COVID, but there is the potential for it to be still move forward at some time in the near future. And obviously that's of really great concern to LGBTI people. There's the issues of reconnecting back into community, particularly during, because we're not sure how long the social distancing or physical distancing requirements will last. So what does that mean in terms of reconnecting back to people, particularly for older LGBTI people who might be in residential aged care, where they have much greater access now due to the sort of framework on visitation rights, but there's still that kind of process of going through and reconnecting back to your community.
Thanks for that. Any concluding comments from the others of you? Cecilia or Barbara?
I think it's been an interesting time. There certainly have been learnings. There are some things that I think we will look at continuing to do in terms of using technology and encouraging people to use technology. One thing, though, we have really learned to appreciate the human interaction, and everyone is certainly looking forward to resuming some normality and getting back to community.
Thank you. Barbara?
Yeah, I'd just like to comment that unfortunately for our community, we are politically engaged as well. So it's really exhausting. A lot of our people lost their homes in the fires in the South Coast and up the North Coast. And then we've had the lockdown, and now we're politically engaged in Black Lives Matters. And we had a Prime Minister come out this morning and say one day was enough, now get over it. And that slavery did not exist in Australia. So we're being gaslighted, as well as trying to cope with this. Our older people and their stories that they're passing on about slavery and about deaths in custody and about Black Lives Matters, that's being undermined by public comment through the media. So I don't think the lockdown itself is going to be very hard to deal with this politicisation that we're dealing with on top of it.
Thanks, Barbara, for giving us that greater understanding of the issues. Thank you, everyone, for listening to our audience and for your questions. And we can see that the historical and discrimination issues have affected community responses, and they need to be taken into consideration when working with our special groups. They are not just the same as everyone else. They have some increased needs that we need to meet, and we need to do more collaboration and make more structural changes. And I guess that's our opportunity to do that now. But thank you very much for joining us today. And if anyone has any needs of any sort, please look at our Seniors' Rights Service website. It's got lots of, it will have videos and webinars from next week onward. We've got lots of informative articles, and you can ring us if you want some legal advice or some advocacy assistance in home care or residential aged care. So the number's on the screen. Thank you again.
Thank you.